Hi everyone. In this video, we will be discussing about diagnosis, classification, complications, and management of diabetic ketoacidosis. I haven't touched etiology and pathophysiology of diabetes ketoacidosis purposefully. That's because if I add those two components also, it will become a huge video in terms of duration. Hence, I restricted myself. So let's get started. I have taken references from three sources mainly. The first one is ISPAD 2022 guidelines. The second one is BSPED 2021 guideline. And the third one is ISPAD textbook of Pediatric Endocrinology. Coming to the diagnosis part of diabetic ketoacidosis, as per ISPAD 2022 guideline, we need to satisfy three criteria to establish the diagnosis of diabetic ketoacidosis. So the first one is hyperglycemia of more than 200 milligrams per deciliter or more than 11 millimoles per liter. The second one is a venous pH of 7.3 or less, or serum bicarbonate of less than 18 millimoles per liter. The third one is ketonemia or ketonuria. It's very easy to remember all these three because when you read the name diabetic ketoacidosis, it has all these three components. The first one is diabetes. So we have to establish diabetes by measuring blood glucose. We have to establish hyperglycemia, to be more precise. Second one is ketoacidosis. So we have to establish ketonemia or ketonuria. The third one is acidosis. Again, we have to establish acidosis by doing a blood gas analysis. And if the pH is less than 7.3, we can establish acidosis. All the three are mandatory to diagnose DKA. And you might have already noticed that serum bicarbonate levels are less than 18 as per ISPAD 2022, the latest one. If you remember, previously it was less than 50. So ISPAD has changed their diagnostic algorithm. However, BSPED guidelines still use the older cutoff, that is less than 50. Coming to euglycemic ketoacidosis, I have already told you that we need to establish diabetes by measuring blood glucose, and we have set a cutoff of 200 milligrams per deciliter. Then what is this euglycemic ketoacidosis? Suppose there's a child with insulin deficiency. He or she is now having ketoacidosis. He is having abdominal pain, vomiting, etc., and he is having altered sensory also. So he is not taking orally, and because of starvation, his blood glucose decreased, even though it has not reached the normal level. So he has ketoacidosis due to diabetes, but still his blood glucose level is not as high as we expect. So that is euglycemic ketoacidosis. So ketoacidosis with only modestly elevated blood glucose concentration is called euglycemic ketoacidosis. So it can happen in states of starvation, a low carbohydrate, high fat diet, or off-label use of SGLT2 inhibitors. Coming to ketone measurement, beta hydroxybutyrate is the main ketone body formed in our body during diabetic ketoacidosis. The other one is acetoacetate. So beta hydroxybutyrate level of more than 3 millimoles per liter is a sensitive indicator of DKA, and beta hydroxybutyrate levels of more than 5.3 millimoles per liter is a very specific marker of DKA. And we all know that serum or blood estimation of ketone body is not available at all centers. However, dipstick measurement for urine ketone is quite easily available. So at many centers, we do urine ketone estimation. So in urine dipstick measurement, if we get 2+, that means there is ketonuria. Urine dipstick ketone levels of 2+ corresponds to blood level of more than 3 millimoles per liter. However, you should keep in mind that in urine dipstick test, it detects only acetoacetate. The main ketone body was beta hydroxybutyrate, which is not measured. So that's a pitfall of using urine ketone estimation. So if you are going by urine ketone, you should remember that it can underestimate ketonemia. Coming to severity of diabetic ketoacidosis, as per ISPAD 2022, there are three broad categories. First one is mild DKA, second one is moderate DKA, third one is severe DKA. So this classification is based on bicarbonate pH levels. If the bicarbonate is less than 18 millimoles per liter and the pH is less than 7.3, it is mild DKA. If it is less than 10 and less than 7.2, it's moderate DKA. If the bicarbonate is less than 5 and pH is less than 7.1, it is severe DKA. Again, you might have noticed the difference. As per ISPAD guideline, the cutoff of mild DKA is now less than 18 millimoles of bicarb. However, BSPED still sticks to the older standard, that is less than 50. Let's go to the most important part of this video, the management of DKA, the trickiest thing in this video. So we all know management has two parts, investigation and treatment. So what all investigations do we need to do? The first one is RBS. Of course, we have to establish diabetes. The second one is blood gas analysis. We have to establish acidosis. The third one is serum electrolyte. Serum electrolytes estimation is one of the most crucial investigation in the management of diabetic ketoacidosis, because we will have to manage hyponatremia, we'll have to manage hypo or hyperkalemia. We may encounter hypophosphatemia, hypocalcemia, and hypoglycemia. So the electrolyte milieu will be totally deranged in diabetic ketoacidosis. So it's very tricky. We have to do a complete blood count, and because infection is one of the most common trigger for development of diabetic ketoacidosis in an insulin deficient patient. So we have to do a total count along with hemogram. However, keep in mind that DKA can cause high total count without infection, because in DKA there will be cytokine production which will trigger total count production, the increase in total count. Then we need to do renal function test, calcium, phosphate, magnesium, and albumin levels. And HbA1c levels are important, especially it will help you in the diagnosis of ketoacidosis if there is euglycemia, in the setting of euglycemia. ECG and X-ray, if needed, we need to do. ECG is indicated if there is hyper or hypokalemia, because both these states can precipitate arrhythmias. X-rays are indicated if you suspect a focus of infection in lungs, or you are suspecting pulmonary edema due to overzealous fluid administration. And you may face a situation where you get a deranged RFT. There is increase in the levels of serum creatinine and serum urea. We all know that the usual range of serum creatinine in children is between 0.3 to 0.8. We may get a serum creatinine value of 1.2, 1.3. That's because serum ketone bodies interfere with the lab estimation of serum creatinine, and that's not because of a kidney injury or a kidney event. So that's important to understand, because in the management of diabetic ketoacidosis, we usually add 40 milliequivalents of potassium to 1 liter of maintenance fluid. That is double the normal range. In normal maintenance fluid, we add 20 milliequivalents of potassium in 1 liter of fluid. Due to risk of hypokalemia in diabetic ketoacidosis, we add the double. So if there is deranged RFT, we cannot add that. And so always remember that if the child is passing urine and there is no previous history of chronic kidney disease, we can safely add double the amount of potassium in maintenance fluid in order to maintain normal potassium levels. You may see a urea value of around 40 or 50. That's because of pre-renal AK component due to dehydration. Coming to goals of management. Goals of management include correction of acidosis and reversal of ketosis, correction of dehydration, restoration of blood glucose to near normal, monitoring for complications and its management, and identifying and treating the precipitating events. Coming to components of treatment. The first component of treatment is the emergency assessment as per PALS guidelines. Whenever the patient comes to our emergency department, the child, most of the children, they might be already dehydrated. You can see small breathing, that is rapid shallow breathing, osmotic breathing. Then they might be in shock rarely. So at that time, we have to stabilize airway breathing and circulation. And they might be having altered sensorium, because of which there is a risk of aspiration. So we have to prevent that also. Second component of treatment is by restoring normal fluid volume by IV fluid. Then third one is IV insulin infusion. The fourth one is management of electrolyte level abnormalities and monitor for complications and its treatment, and of course identification and treatment of precipitating event, which is usually an infection. Coming to fluid therapy, it's one of the most trickiest component in this DKA algorithm. It's tricky because we have to give adequate amount of fluid, otherwise the DKA won't improve. If you give excess amount of fluid, that is overzealous fluid therapy, can precipitate the most dreaded complication of DKA management, that is cerebral edema. So it has to be perfect. Again, as per ISPAD and BSPED guidelines, the degree of dehydration is given in that table, which you can see. In mild DKA, the estimated dehydration is 5% in both guidelines. In severe DKA, the estimated dehydration is 10% according to both the guidelines. However, in moderate DKA, there is a difference. What makes fluid therapy difficult is that the assessment of dehydration diabetic ketoacidosis is very difficult. What happens in DKA is that there is excess glucose in intravascular compartment due to lack of insulin. Because of excess glucose, it ranges from around 600 to thousands. There will be increase in serum osmolality. Because of serum osmolality, intracellular and interstitial fluid will be dragged to intravascular compartment. Again, that fluid won't remain in the intravascular compartment. That fluid will be drained by kidney due to glycosuria. Whenever glucose goes above 180, glucose will get excreted by urine, and it will be associated with diuresis. So what happens is that fluid will come from intracellular compartment and interstitial compartment to intravascular compartment. From there, it will be drained. So intravascular volume will be relatively fed till the later stages of decay. So you won't get 30 pulse or hypotension in the initial stages. Rather, you may get hypertension in 10 to 12% of cases, because whenever there's fluid loss, there will be aldosterone axis activation, renin-angiotensin aldosterone activation, and there will be activation of vasopressin. And the most important one is, if you go back to the pathophysiology of diabetic ketoacidosis, you remember it's not just because of insulin deficiency. There is excess of counter-regulatory hormones, which are crucial for the pathogenesis of diabetic ketoacidosis. So what are the 4 key counter-regulatory hormones? They are growth hormone, cortisol, glucagon, and catecholamines. So what happens whenever there is excess of catecholamines? There will be hypertension, right? At least it will maintain BP in the normal range. So you can expect a normal BP, even a higher BP in diabetic ketoacidosis. So don't expect a big BP to fall initially. Then, since clinical assessment of dehydration is very difficult, we have to resort to some biochemical parameters to assess dehydration. Studies have found that higher serum urine nitrogen and lower pH corresponds to severe dehydration. So what is the choice of fluid? There's a landmark study which is published in the year 2018. It is known as PECARN trial. Before that, I will tell you about some other study which was conducted in the year 2000. It was an observational study conducted in the year 2001 by Nicole Glaser et al. They tried to find out all the risk factors for cerebral edema in diabetic ketoacidosis, and they found out that fluid rate or choice of fluid is not a parameter which interferes with the pathogenesis of cerebral edema. However, a follow-up study was conducted and it was published in the year 2018. It was almost a 9-year-long study, a randomized controlled trial. Some of the others, if you look, they are common in both the studies. And the second study is known as the PECARN trial. This study is adopted in many guidelines, so it's important that we know what happened in this study. In PECARN fluid trials, the study population was divided into 2. In one arm, the investigators gave rapid infusion for DKA correction. In the other arm, they gave slower infusion of fluids for DKA correction. They subdivided each arm into two, and for one group they gave half normal saline, and in the other group they gave normal saline. So they have four categories of study population. One, rapid infusion with half normal saline. Second, rapid infusion with normal saline. Third, slow infusion with half normal saline. Slow infusion with normal saline. What was their finding? Their finding was they found out that there is no significant difference in neurological outcome between all these four groups. This means that there is no different association between fluid rate or choice of fluid and neurological sequelae. This was a landmark study because it broke many myths about pathogens of cerebral edema. So we got a hint that it's not just about sudden decrease in serum osmolality which causes cerebral edema. We need to ponder about other factors also. However, it was not a flawless study. There were deficiencies. One of the deficiencies was only 10 to 12% of the study population were under the age group of 6. We know that younger the population, more the risk of cerebral edema. So if they haven't included more younger children, how can they say that this study is internally and externally valid? And children with GCS of less than 12 were excluded from year 2 of trial. That means the sickest children were not included in the study. These two were the deficiencies in the study, because of which we cannot completely generalize this study in all populations and across all situations. If you're more interested, you can go to this website, Don't Forget the Bubbles, and there's an article written by Mr. Ben Lawton. It explains very well what happened in this PECARN trial and the positives and negatives of this trial. Coming to resuscitation phase of fluid therapy. So whenever the child comes to emergency department, this is what we administer. So if the child doesn't have shock and he has severe DKA, we have to give 10 to 20 ml per kg of fluid, that's normal saline, over 20 to 30 minutes to restore peripheral circulation. The same is given in both guidelines. If you remember, we used to give the same amount of fluid over 1 hour, but as per PECARN trial, now the duration has changed. Now it's 20 to 30 minutes is the duration. However, remember that PECARN trial, very sick children were not included. So if the child is in altered sensorium and if you're suspecting a CNS injury, it's better to continue giving bolus for 1 hour. If tissue perfusion is poor, the initial fluid bolus should be 20 ml per kg. I will explain about what is poor perfusion and what is the difference between shock in the next slide. If the patient is in shock, rapidly restore circulatory volume with 0.9% of saline in 20 ml per kg bolus infused as quickly as possible with reassessment of circulatory status after each bolus. So this is same as any other case of shock, because in shock, the tissue perfusion is very much compromised. You have to rapidly infuse volume of fluid so that normal cellular respiration is attained. There is a difference between ISPAD and BSPED guideline in shock. If in DK with shock, ISPAD guidelines say 20 ml per kg bolus infused as quick as possible. It's okay. But in BSPED guideline, that is the British guideline, they suggest that initially we have to give only 10 ml per kg, administer as fast as possible. After giving 10 ml per kg, you reassess, and if there is a need, you can give further. In ISPAD, if there is shock, give 20 ml per kg as fast as possible. In British guideline, you give 10 ml per kg, then reassess. If there is a need, give again. That's the difference. If the initial bolus is not sufficient, you can still continue giving 10 ml per kg bolus up to a maximum of 40 ml per kg. Even after giving 40 ml per kg of fluids, the BP is not maintained, then consider inotrops, because there might be a component of septic shock in this DKA patient. Poor perfusion versus shock. Previously, if you remember, I told that if there is poor perfusion, you have to give 20 ml per kg bolus. That was over 20 to 30 minutes. If there is shock, you have to give 20 ml per kg as fast as possible. So what is the difference between poor perfusion and shock? Remember, in DK, there is severe acidosis. Because of severe acidosis, there is Kussmaul breathing, and because of Kussmaul breathing, there is hypocapnia. Both acidosis and hypocapnia can cause peripheral vasoconstriction. So even before the development of shock, there will be peripheral vasoconstriction, because of which there will be poor perfusion in peripheries. So we cannot say the child has shock just because he or she has a poor perfusion in peripheries, that is cold peripheries. So shock is defined based on presence of tachycardia, prolonged central capillary refill, etc. It is not just poor perfusion. So NICE guidance 18 emphasized weak thready peripheral pulses and hypotension as features of shock. So DK with normal blood pressure and cold peripheries, you have to give 20 ml per kg or 20 to 30 minutes. DK with thready peripheral pulses and hypotension, we have to give 20 ml per kg bolus as fast as possible. Then deficit replacement fluids. After initial bolus, we have to give maintenance. So what we usually do, the DK, we start a dehydration of 8.5%, what we follow in usually in all the centers. So in children presenting with shock, we assume at least 10% dehydration. If child has severe DK without shock, we assume 8.5% dehydration. In DK with shock, we consider at least 10% dehydration. And we aim to correct the dehydration and acidosis over 48 hours, because if you rapidly correct, there will be a sudden decrease in serum osmolality, which will lead to cerebral edema. So infusion rate is, for each percentage of dehydration, we have to give 10 ml per kg fluid. So if you are starting with 8, assuming that there's 8.5% dehydration, you have to give 85 ml per kg. That is for dehydration, total net fluid loss. And we are planning to correct over 48 hours. So 48 hours means 2 days. So you have to add twice the maintenance fluid, because we are calculating for 2 days. And you have to subtract the bolus, and we are dividing it by 47. Why not 48? That is, we are correcting it over 48 hours, but we are dividing it by 47. Why? Because we have already consumed 1 hour for giving bolus. So this is a formula. So 85 ml per kg, because for each percentage of dehydration, we have to give 10 ml per kg. And if we have to add 2 times the maintenance fluid, because it's for 48 hours. And we have to subtract the bolus, and we have to divide by 47. Always remember that if it is an obese child, you have to keep a cutoff of 75 kg as a maximum weight allowed in this calculation, in order to avoid overzealous fluid drag. If you are given boluses to correct shock, those boluses should not be subtracted from this equation. If it's just a severe DK without shock, and you give 10 ml per kg bolus, that has to be subtracted. But if it's a DK case presented with shock, and you give some 20 ml per kg fluid to correct the shock, to bring back normal tension, then that bolus should not be subtracted from this IV rate. Coming to the fluid of choice. The fluid of choice is normal saline till the blood glucose levels reach 250. Plasmate A was tried, and plasmate A has an advantage because normal saline has excess of chloride. Whenever we give chloride, in order to maintain electrical neutrality, body will excrete bicarbonate, which is also a negatively charged ion. So what will happen? If chloride excess happens in our body, it will lead to normal anionic metabolic acidosis, because bicarbonate is lost. So in order to avoid that, we balance salt solutions like plasmate. But however, there is no significant difference between these two fluids, so we usually use normal saline. Coming to one example, how to calculate fluid for 20 kg child with severe DK without shock. So initial bolus will be, so this is a child without shock. So we will give 10 ml per kg bolus. So 10 into 20, 200 ml over 1 hour. As per new guidelines, we can give over 20 to 30 minutes. Then deficit replacement, you have taken 8.5% dehydration as a rule of thumb. So we give 85 ml per kg plus 2 times the maintenance fluid. Maintenance fluid can be calculated using Holliday-Saga formula. For first 10 kg, you take 100 ml per kg. Next 10 kg, you take 50 ml per kg. After that, for each kg, you take 20 ml per kg fluid. So for a 20 kg child, it will be 1500, and we have to subtract the bolus, that is 200. Divided by 47, we will get 95.7 ml per hour. Suppose the same child presented with shock. If there is shock, we have to give 20 ml per kg bolus as per ISPAD guideline. So we have to give 400 ml as fast as possible. After that, suppose child improve after that, we won't give further boluses. Then deficit replacement. I told you, if there is shock, we have to take the dehydration as at least 10%. So for each percentage of dehydration, we have to give 10 ml per kg. So for 10% dehydration, we have to give 100 ml per kg. So 100 into his weight 20, her weight 20, then 2 times the maintenance fluid, that is 2 into 1500. And we won't subtract the bolus because the child present in shock, divided by 47, so it will be 106.3. Then in severe shock, we usually insert a saline for the management because we have to give inotrops and all. So in DK, is it dangerous? There is significant risk of femoral vein thrombosis in young and very sick children with DKA who have femoral veins inserted. If at all you want to insert a line should be inserted as short time as possible. So we have to remove it as soon as possible. And thromboembolic prophylaxis is recommended for children older than 16 years. Coming to the second part, insulin infusion. We started correcting dehydration using fluids. Of course, if you give fluids, acidosis part also will start coming down. The second part of therapy is insulin, because insulin deficiency is a cornerstone of this problem. No role of bolus insulin. You have to give infusion. And always remember, don't give insulin in the initial hour of resuscitation. That's because if you give insulin along with the fluid bolus, it will rapidly reduce the serum osmolality, which will precipitate cerebral edema. So wait for 1 hour, let the bolus finish, only then you start insulin. Make a 1 unit per ml solution of insulin normal saline. You can take 50 units of insulin 50 ml saline or 40 units of insulin 40 ml saline and start infusion at 0.05 to 0.1 units per kg per hour. Insulin has a tendency to get absorbed to the plastic tubings. So before connecting to IV cannula, suppose you made a solution of 50 units in 50 ml. You have to flush out at least 20 ml of the insulin solution through the tubing so that all the binding sites available in the plastic tube get saturated with insulin, so that water fluid now goes through the tubing has insulin. Then once the glucose falls below 250, you have to shift to dextrose normal saline. We have to start dextrose normal saline even early if there is a rapid fall in random blood sugar. That's because our purpose of management is not just decreasing glucose to normal level. Our purpose is to correct dehydration, to correct acidosis. For the correction of acidosis, we need insulin. So if glucose is rapidly falling, we have to supplement glucose in order to avoid hypoglycemia so that we can continue with insulin infusion. Also, if the glucose rapidly falls, then cerebral edema may be precipitated. We have to bring down glucose at a very slow rate. And if the glucose levels are still going down despite starting DNS, we have to gradually increase the concentration of dextrose in the fluid. We can do that by mixing dextrose normal saline with D25, and we can go up to 12.5% of concentration of dextrose. And if even at that point of time, if you can maintain euglycemia, you can decrease the concentration of insulin. If the child is already on long-acting insulin, you can continue that, because studies have found that if you're continuing long-acting insulin, the recovery time is less, so you can continue with long-acting insulin. The children who are on continuous subcutaneous insulin infusion of therapy, stop the pump when starting insulin infusion. When the acidosis is corrected and when the pH is almost normalized and the child is now free of any severe symptoms, you can start subcu insulin. When you start subcu insulin, you have to run insulin drip for another 1 hour so that rebound hyperglycemia does not occur. Coming to potassium infusion. So we give potassium at a concentration of 40 milligrams per liter in maintenance fluid. We usually give 20 milligrams per liter in normal settings, in a normal child for some other reason, because that's a normal concentration. But what happens in DKA is that because of acidosis, potassium comes out of cell. Potassium will remain in intravascular space. And I've already told you that there is hyperaldosteronism due to loss of fluid from body. Due to excess aldosterone, whatever potassium comes into the intravascular space, it will be drained out. And because of acidosis, potassium is coming out from the cell also. What we see is that when we measure potassium, it will be in the higher normal range in serum. However, DKA is a potassium drain state. Even though the serum values are in the normal or higher normal range, there is deficiency of potassium in the body. So we have to start with double concentration of potassium. And we know that when we correct shock by giving fluids, if shock is corrected, acidosis will improve. If acidosis improves, potassium will go back to intracellular compartment. So if we are correcting shock, remember that potassium will suddenly decrease, and on top of that, you are giving insulin also. Insulin will shift the potassium from intravascular compartment to intracellular compartment. Again, it will precipitate hypoglycemia. We need to measure potassium every 4 to 6 hours and titrate potassium in the infusion. In the peripheral line, what is recommended is that we shouldn't go above 40 milligrams per liter, but we usually go till 60 milligrams per liter. If you need to go above that, then we have to use a central line. We have already told that central line insertion is not that safe in DKA. So we usually titrate insulin and manage potassium. Suppose the patient presented with hypokalemia, that is already the intravascular potassium is low. What if we give a fluid bolus to that person? The acidosis will improve with fluid bolus. So hypokalemia will be worsened, which can precipitate arrhythmia. So at that time, if you have a documented hypokalemia admission, then even in the resuscitation fluid, you have to add potassium at the concentration of 20 milligrams per liter. Normal maintenance fluid concentration of potassium, even in the resuscitation case. If there is hypophosphatemia also, instead of potassium chloride, we can add potassium phosphate. And always remember that 1 ml KCl contains 2 milligrams of potassium. However, 1 ml phosphorus contains 4 milligrams of potassium. So while changing to potassium phosphate, you have to remember that hot phos solutions contain double the amount of potassium as compared to hot chlor solution. Not a calcium if you are giving phosphate, because if you are giving phosphate, hypocalcemia can precipitate. Suppose the patient presented with potassium of say 6 milligrams liter, which is in the range of hyperkalemia. So at that time, if you can make sure that the child has urine output, you can still add potassium to maintenance fluid, or you can wait for some time and let the potassium come down to normal range. At that time, you can add potassium. If there is hypokalemia at admission, after giving bolus, you have to defer insulin for some time. You can continue maintenance fluid for DKA, but you have to defer insulin for 1 or 2 hours. More than 3, you can stop insulin, because insulin can precipitate hypokalemia. Oral potassium supplements that we usually don't give, because in DKA, because of acidosis, there is recurrent vomiting in child. If you give potassium supplements, which we all know, most of the practicing pediatricians know that, it can precipitate vomiting again, it can worsen vomiting. Potassium supplements are known for causing gastritis and vomiting. So if central line is not available and child can take orally, can give oral potassium supplements to maintain normal potassium levels. Can we give bicarbonate infusion? We might be tempted to give bicarb for correction of acidosis, because pH will be in the range of 6.8, 6.9, 7, etc. However, remember that bicarbonate administration is not recommended except in life-threatening hyperkalemia or severe metabolic acidosis, that is pH less than 6.9, with evidence of compromised myocardial contractility. Bicarbonate therapy can cause paradoxical CNS acidosis, and rapid correction of acidosis with bicarbonate causes hypokalemia. As far as possible, avoid giving bicarb. It will be detrimental to the health of patient. Infection is a common trigger factor for DKA, because infections can cause rise in counter-regulatory hormones in the body, which can precipitate DKA. Fever, hypothermia, hypotension, raised lactate, and raised inflammatory markers may all indicate possible concomitant infection. And in DKA, we know that there is high anion gap metabolic acidosis. So the anion gap will be in the range of 20 to 25. If it is more than 35, you have to suspect that some other factor is causing that high anion gap, which is usually a septic shock. So if the anion gap is more than 35, always consider sepsis. You can start first-line antibiotics if you're suspecting infection. The choice of antibiotic depends on the institutional policy and institutional guidelines. Coming to the concept of corrected sodium. In DKA, there is increased serum osmolality due to high serum glucose, which will drag the fluid from intracellular interstitial compartment to intravascular compartment. So what happens to sodium? Because there is excess fluid in intravascular compartment, the sodium gets diluted and there is dilution hyponatremia. What is corrected sodium? Corrected sodium represents the expected serum sodium in the absence of hyperglycemia. So if hyperglycemia was absent, what would have been the sodium level? That is corrected sodium. So we can calculate corrected sodium using this equation, that is measured sodium plus 1.6 into glucose minus 100 divided by 100. So in simple terms, it means you add 1.6 for every 100 glucose above the level of 100. What's the use of measuring corrected sodium? Suppose you have started maintenance fluid and you are measuring electrolytes every 4 to 6 hourly, and you have noticed that the corrected sodium levels are increasing rapidly. That is more than 5 millimoles per liter in 4 to 8 hours. That means that there is severe dehydration and you are providing fluid at an inadequate rate. What if there is decrease in corrected sodium levels? That is, you are giving a fluid with high amount of free water. That means you have to increase the sodium content of fluid, or you are giving a normal sodium containing fluid at a rapid rate. That's why there is increase in free water in the intravascular space, because of which there is fall in corrected sodium. So if corrected sodium is rapidly increasing, that means the correction is not adequate, increase the fluid rate. If the corrected sodium is coming down, that means there is more free water in the compartment, or there is a rapid correction of the osmolality, and we may need to increase the sodium concentration of the fluid, or we may need to decrease the fluid rate. Despite doing everything right, what if the blood glucose doesn't improve? The possible causes are we are not giving sufficient amount of insulin. There, the cannula might not be working properly. We will ask the nurse who prepared the insulin infusion whether he or she has flushed the tubings or not. Then we will consider sepsis and we will give antibiotics. Then if acidosis is persisting despite all the treatment, and we have to recheck our insulin, then we might have underestimated the fluid loss. We might have given inadequate fluid, so we have to increase the fluid rate. Then it can be due to food calculation error, it can be due to sepsis, it can be due to hypochloremic acidosis. I've already told you, increase in chloride can lead to normal anaemia metabolic acidosis, but you can differentiate it between DKA and acidosis caused by excess chloride by measuring anion gap. If you are giving normal saline, it can cause normal anion gap metabolic acidosis, but it will improve DKA, because of which anion gap will come down. So if anion gap is improving, then you can be sure that the treatment is working. This hyperchloremic acidosis is, it's nothing to worry. It will improve on complications. The drug complication is cerebral edema, which is unpredictable, and it usually occurs in younger children and newly diagnosed diabetes. It has a mortality rate of around 25%. Hypokalemia, it's preventable. You have to increase the concentration of potassium in the maintenance fluid, or you can decrease the rate of insulin. Aspiration pneumonia, if the child is not in proper sensorin, he or she can aspirate. At that time, you can insert a nasogastric tube and aspirate all the stomach contents. The most dreaded one is cerebral edema. The treatment of cerebral edema is quite simple. We'll keep the head in elevated position. We give 3% saline and mannitol as per the institutional protocols. We need to examine every hour for the GCS status to establish a diagnosis of cerebral edema at the earliest. The risk factors for cerebral edema before admission at hospital, they are NH, new onset DKA, longer duration of symptoms. At presentation, if child has shock or has severe hypocapnia or increased urea and creatinine or severe acidosis, he or she is at high risk for cerebral edema. And on therapy, if child received overzealous fluid therapy, or he was started on insulin in the first hour itself, or rapid correction of osmolality, I already told you, and use of Bicarbonate, all these factors can lead to cerebral edema. And the management of cerebral edema, I have already told you. Thank you for patiently listening. If you like this video, consider subscribing to my channel, and you can mail me. Thank you.